All right, welcome everybody. This is the National Care Coordination Academy. It's so nice to see you all. We have an awesome day planned for you as usual. So we're happy to have you all back. Right now, I'm going to hand things off to Rich Antonelli to give us all a welcome.
Thank you, Heather. And thank you to the team that set up today, make it possible. As always, I want to acknowledge Heather, Mela, Erica Norkis, Jessica Flaherty, and Jeff, Renee, Steve, Meg, of course, and the folks from the BU team. But before we launch into today's Academy session, I do want to welcome us, but I also want to pause for about half a minute. We're all in this work together. We are a part of a global community. It's painful for me personally, and I'm sure for us collectively, to recognize that there are families, children that are in harm's way right now. So I'd like to ask that we all take a few moments for reflection, reaching out, if you can, with your minds and your hearts, recognizing that our work is very precious. And thank you. Thank you. What calls us each day, either as persons, members of our own families, or professionals in whatever capacity, it is about the children, it is about the families, and it's about that sense of community. So thank you for what each of you do individually and collectively. So I want to welcome us to this session at a high level. You're going to hear some familiar themes today, thinking about transitioning youth with special healthcare needs from pediatric to adult care. But we're going to really have many variations to that today. We're actually going to be talking about what's life like on the other side of this so-called transition bridge. I won't get into introducing all of the panelists at this juncture, but I want to kind of set the stage. Reinforce measurement is important. Reinforce the idea that we have tools at our disposal to advance this field. But something that I especially want to call out is this idea of justice, social justice, health justice, the notion of how does our work impact persons, not just patients, but persons and families. So that's what today is really going to be a strong focus on, will be health justice. I hand over to Meg in one moment, but I want to call something out that's very important. We're going to be rescheduling the meeting that you currently have in your calendars for May, which was scheduled to be the last Care Coordination Academy session. We're actually going to be moving that into June. And I won't burn much clock time now talking about why, but at a high level at the beginning of June, the Maternal Child Health Bureau blueprint will be coming out. And the leadership of the Care Coordination Academy felt that having the concluding session of this academy in June after that launch will fit very beautifully with some issues around transition. So I want to hand it over to you now, Meg, to complete the introduction.
Thanks so much, Rich. So welcome to the penultimate Care Coordination Academy meeting, and thanks very much for making the time to join us today. We are very much excited about today's topic. We think it may be a little different than what you typically have experienced in talking about the topic of transition. We are very excited also to have group of panelists who are experts in their own individual areas, and together they provide a shared voice that I think we're all going to benefit from learning from and with, and we're looking forward to the discussion with you all to come. I just wanted to say a couple of quick things from my own personal perspective. On a typical day, I wear two hats. So I have Meg, the policy wonk hat, and I have Meg, the mom of a now young adult who was born with a complex genetic syndrome. And on a typical day, those are pretty comfortable and complementary hats to wear at the same time. And for today's topic, that's no different, but there is a sense to me of both some heightened responsibility around it and also some heightened urgency around it. With my policy wonk hat on, I think about how the insufficient spending that we currently as a society provide on healthcare for kids becomes for many families a crisis when their child turns 18 or 21 or 22 and they are no longer eligible for services and supports that they had been previously eligible for as children. With my mom hat on, I think about how inherent ableism allows that crisis to happen in our society. And with both hats on, I would feel that we have made significant progress if we can stop thinking about spending on healthcare for people with disabilities and other complex care needs, and instead think about investing in people. And that means investing in them early as children, but also to continue investing in them as they become adults and as they move through their life course. So that to me is the primary challenge of justice that we face in the context of transition, and a conversation that we are very much looking forward to having with you all. So thank you in advance for your time, for your attention, and for the wonderful learnings that I'm sure that we are all going to experience today. I'm going to turn the floor back over now to Rich and Heather to bring us into our first set of slides. Thank you.
Thank you so much, Meg and Rich. That was a wonderful welcome. I'm just going to go over a couple of our usual housekeeping slides just to remind you. Today's meeting is being recorded, but your team breakouts will not be recorded. Please do not use speakerphone or put us on hold. We enjoy the hold music sometimes, but it's a little distracting when we're in the meeting. We do want you to please rename yourself to include your state team abbreviation. This will be very helpful when we do get to the team breakout area. It's much easier to move you to the correct group if we can see directly where you belong. And the chat will be moderated. We encourage you to put your questions, comments, resources, anything, please go ahead and put it in there. And we will try to allow for time for both responses to the chat, but then also welcome you to come onto the podium to ask your questions as well. If you're using a phone and your computer, please link them so we can see you as one name on the participant list. Just to briefly show you how to rename yourself. So you're going to go down to the participant list. You'll then find your name and you can right click on it and hit rename and then put your state team abbreviation before. Today's session and all of our sessions are eligible for continuing education credits for participants who are RNs, NPs, MDs, PAs, and social work. To do this, you must, to obtain your certificate, you must put your information on the attendance Google Doc, which Erica will share in the chat. We'll share it again later, and then I'll also share it from email later tonight. If your facility does not allow you to access Google Doc, don't worry, just send me an email with your information and I'm happy to add you. Please be sure you fill in all sections, including what your profession is and your email address. After you do the attendance Google Doc, later today we'll share the Academy evaluation. Once you've completed both of those items, your information will be sent to Boston Children's CME department. And in about 2 to 3 weeks, you should receive an email from them outlining final steps to obtain your certificate. If at any time you have questions about this process, please feel free to reach out to me. And if anyone from your team is not here today, but does want to view the recorded lecture, they can do that, and up to 6 weeks, they can still request CEUs. Okay, so we have a great agenda planned for you today. Just going to give you a quick overview. So we're in our welcome and opening remarks now. We're then going to jump into our panel discussion with the topic transition as a justice issue, and LTSS can be a crossover bridge. We have some excellent panelists today. And then we're going to take a break from 1:40 to 1:55. We'll then come back and jump right into team breakout groups. I sent you the breakout group instructions from an email last night. Please be sure you can access those when we get to the team breakout groups. We'll then come back together for a group discussion, and then we will do our closing remarks and wrap up. I do want to make mention now, we're going to talk about this at the end, but I know some people can't make it through the entire meeting. We will be talking about the Academy evaluation that will be coming out shortly in the next few months. And it's going to be evaluating your participation over the last 2 years with us. We've been so grateful for your participation, and we really want to hear how it was for you and what you learned. And so you'll be hearing more about that. Jeff will give you some more details on what that will look like. The learning objectives for today. After this session, participants will understand the critical role of long-term services and supports, otherwise known as LTSS, can play in improving health outcomes for persons with complex chronic needs across the age spectrum. Participants will also identify opportunities for adult and pediatric LTSS to meaningfully engage and create a bridge, especially a crossover in models of care, outcomes, measurements, and policy spheres. And lastly, you'll gain knowledge with how care coordination tools, processes, and measures can support an equitable approach to transition and transfer of young adults and adults with complex needs. Jeff, I'm going to hand things over to you.
Great. Welcome, everyone. On this, our second last Academy meeting, I just want to reiterate how humble I am by the work that this group has done. So it's an honor to participate. This quote is on my wall. I put it up a little while ago, and I just want to go back to it because we're at this transition stage where we're talking about transitions and LTSS between youth and adults, but we're also in this transition phase for this academy as it winds down, but our work never does. And the quote, "You are not obligated to complete the work, but neither are you free to abandon it," is sort of, I guess I would say, a lifelong mission, I would say, for everyone on this call. We work on these issues all the time. We're passionate about it, and we have have done a lot, hopefully. I'm going to do a little bit of a very high level to say that we introduced this idea of a three-legged stool of our care models, sustainability, and measurement. Hopefully we've spent enough time talking about the true partnership role for parents and for people who are in underrepresented communities, and have talked about that as a justice issue as well. But the issue we're talking about today is really, I think, a justice issue that we often don't spend enough time with and on the pediatric side, but it's time for us to look at. If you go to the next slide, our bridge here is really significant. Transition is a justice issue, and LTSS can be the crossover. There's a lot of variability in how states look at long-term services and supports, and I know this from my own state and then know it from looking at other states. There's waivers, there's managed care, there's all kinds of those technical sorts of things that get in the way sometimes, but also facilitate sometimes people having the ability to be present in communities. I want to say that what is sort of I think some people know, but let's just remind ourselves, is that Medicaid is almost in equal parts a medical program and a long-term services and supports program, and depending on what state puts money where. There's also real variables in terms of how families and communities can access these services. But it's really what families and individuals need to get to their optimal health and well-being. Next slide. We're going to do a couple things at the beginning of this panel just to get it off. So we're going to really interweave these three themes: the transition to appropriate transitions of youth, need for LTSS systems at work, and we've talked about this as a justice issue. We have 3 polling questions we want to get you engaged in, just kind of level set a little bit, and I'll go through these real quickly. First, next slide, Heather, if you want to go up to the next one. We'll just do these and just to see where everyone's at. The first polling question is, is that question 3? You're backwards, I think.
Whoops,
Has
I don't know
your
how I did that. Hang on. Okay, ready? Here's one.
okay. Has your team included transition planning in your care model? Yes, no, partly, or unsure. So I'll give you a minute just to see where you're at with this.
I can let you know once we have a good amount of people participating. We're getting up there
Yeah.
already.
Great.
We can do another like 15 seconds and then I'll share the results.
Great. And these questions are just really to let probably the panelists and everybody know where everybody's at.
Okay, I'm going to share the results. All right.
So most are yes, great, and partly, and a few unsure, and a few that haven't gotten a chance to do that. Okay, let's close that and let's move on to the next question, question number 2. Does your team screen and plan for LTSS services? So I guess this is more of a system level structure thing. We just wanted to see where everybody's at.
We're pretty split on this one. I'll post in just a few seconds. Let's see. Okay, I'm going to share the results, Jeff.
Great. Yeah. So 29% seems to be the number we can remember, but
Yes.
a few haven't at all. But I think this is really an important thing to see, that we have, even as we're launching everybody, we have some work to do here. And then the last question is really about this infrastructure of your team. So if we could go to the last one.
Okay.
And you got it?
Yeah,
Okay.
this one, because I already shared it in the beginning. It won't let me share again, unfortunately. Whoops.
Okay.
All right. We can talk about this one out loud.
Okay. Oh, we can't do it.
No, because I
Okay.
shared it, unfortunately, in the beginning.
Okay. So I think we'll put this in the chat and people can respond, but it's really about infrastructures. Does your Care Coordination Academy team include members with lived experience, expertise with LTSS? So I think that's where we really wanted to go to see if folks were represented. Alrighty. Yes, from Minnesota. I'm looking to this. Please add your comments to the chat here. So.
Oh, it just worked, guys.
Oh.
It just loaded.
Okay, there you go. Let's do it.
It
Let's
wanted
start.
us to do it. There we go.
Okay, great. Okay, so we'll go ahead and do it.
Going live now. Awesome.
All right, let's see where we're at.
Alrighty, I'm going to share the results now.
Yes. Wow, that's awesome.
It is.
Yeah, great. Okay,
Guys.
let's close these out. We have 3 perspectives today, and I think both Meg and Rich alluded to this. So we are thrilled to have these our guests, and then the perspective from Heather on the provider side. But Dennis, I'm going to let Rich do the intros here, but it's a pleasure to work with Dennis anytime I had the opportunity. I had the opportunity a while ago on a paper about equity, and Jill likewise has been a Medicaid medical director and is now works on the policy and provider side. But I'm going to let Rich do better intros. So I turn this back over to you, sir, and then to get our panel going.
Thank you. And Dennis, apologies that we misspelled your name on that slide. Everyone, I am thrilled to introduce a friend, a colleague, a mentor that I've had the privilege of knowing really just for a few years. He has changed much about the way I think about how policy is made. So Dennis Heafy is an MPH, an MED, and an MDiv. He's a health justice advocate and a researcher at the Massachusetts Disability Policy Consortium. He loves stretching his IQ by attending meetings with people far more intelligent than he is, although I'm not sure that I would agree with that. He often stretches our IQs. A person with a disability, Dennis is grateful for the opportunity to engage in work that demands human and civil rights of people with disabilities of all ages and backgrounds be respected, not just in word, but in praxis. And then just adding, a personal statement. Dennis brings authenticity. By design, he's on the other side of the bridge. And I will preempt something because Dennis is given to humility. He'll be the first person to say, what do I know about kids with special health care needs? But he's been ravenously hungry to learn. So what he's coming for us today is that approach to building that bridge of transition. The next panelist is also a dear friend and colleague from whom I've also learned a lot, Jill Morrow-Gorton. She's a developmental and behavioral pediatrician, associate professor of pediatrics and family and community medicine at the University of Massachusetts Chan Medical School. She has clinical experience working with both children and families and adults with disabilities, including transitions from pediatric to adult services. She's also worked at a policy and program level with a broad range of populations of children and adults with disabilities and special health care needs in both Pennsylvania and Massachusetts, focused on coordination of care between disability and healthcare services. And lest anybody think that we are limiting this discussion to Massachusetts and Pennsylvania, absolutely not. So Jill and I are both on the CMS advisory, the Corset Review Committee for Adult and Child Medicaid. Dennis Heafy is on the so-called MAC PAC, the Medicaid and CHIP access program. So we have truly the privilege of two nationally known, incredibly humble and wise people today. So with that as the intro, I'll hand it over. I think, Jeff, is it to Dennis or to you?
Sorry, we can go right to Dennis.
Okay, Dennis.
Thanks, Rich. Thanks, everybody. And I really am humbled to be here because I'm not a person that was born with a disability or became disabled early due to a genetic condition. Uh, I was disabled due to a spinal cord injury in God, years ago in 1984. I'm almost 85. And I was actually working with folks with developmental disabilities down in Central America at the time. And for me, uh, I was outraged at the fact that there were all these kids, probably most autistic or the developmental disabilities, wandering around the streets, no place to go, nobody, no school, and so during the day, I would just gather with them, hang out with them, and just bring them different places around the village. So for me, my experience with health justice for folks with kids with disabilities really began there, as well as probably earlier in high school. But say it was really started in Belize, working with these kids, and I don't view this as an altruistic sort of uh, venture. This is about people's dignity. It's about their human rights. And it's about providing people the services that they need to realize their human and civil rights. About 10 years ago, and which is talking about yourself all the time. I guess I will talk a little bit about myself before get into more conversation about policy work. Um, when I sustained my spinal cord injury, I was petrified about what would happen to me. Would I end up in a state hospital? Where would I go? I was an adult. My parents' home was inaccessible. I definitely did not want to go into my own parents' home, but I also did not want to go into a nursing home. And I had the opportunity to go to a transitional living facility out in Minnesota. It was called the Courage Center. Fantastic place where I actually learned about what it meant to be a person with a disability, not to be a person with a spinal cord injury. And I make that distinction because oftentimes people who acquire disabilities view themselves as being different from or apart from other folks with disabilities. In fact, I don't even like sharing with people in general how I became disabled because there seems to be this differentiation between folks who are defective because they were disabled from birth and folks who are broken and otherwise would be able-bodied. And so for me, that distinction is part of the ableist view of society that really needs to be done away with. So at the Current Center, I was surrounded by folks with all sorts of disabilities that were like me transitioning to the community. This was the program where people could go to stay for a time, to learn skills, and to really decide what they wanted for themselves, what would be available for them in the community. One of the folks I actually met there was this guy Jim Grimm, who became lifelong friend of mine. And watching his family, watching him struggle to get the LTSS services he needed to live in the community was exhausting. But thankfully, his family had some means and were able to provide him with services, and he lived independently, despite the fact that he was nonverbal, had tremendous difficulty with eating and with communication. Uh, and yet his parents were able to support him in getting to living independently. And I think he's got a short autobiography called The Alphabet of the Heart, and it's about his life as a person with a complex disability. And I believe that Jim was 4 or 5 years old before his parents even knew he was able to read, before they knew his cognitive ability. And that's because his sister was playing with him in the back seat and started doing ABCs, and Jim started sticking his tongue out, and his sister realized that and she was able to track his tongue sticking out. So the fight began with his family and getting Jim the services he needed in school. Then after school, it was getting Jim the services he needed in the community. And Jim's dad was a ferocious civil rights leader and actually was very involved with passage of the Americans with Disabilities Act. And for him, it was about ensuring that Jim had the right to the services he needed to live in the community, to live a life of dignity. And so LTSS was not about medical, and that the medical necessity uh, requirement, that idea that LTSS is about medical necessity, really needs to be rethought. We need to do away with that because even though Jim needed needed surgery, he needed other interventions to support his ability to live in the community. Those surgeries, those things that were done to support his ability to remain in the community. It was not about Jim's medical needs. It was about these are services to support his ability to live in the community. I experienced that. I experienced that myself with so many different people, and in my own life. But I'll share a little bit more in a minute. For me, home and community services are about supporting people's right to live in a least restrictive setting of their choice and have services provided to them by and whom they choose. This is a health equity issue and is a health justice issue. It's a health equity issue because people with disabilities are, by the very nature of our abilities, require supports that we need to maximize those abilities and the abilities of our families to live in the community. This is not just because of our medical situations or even because our HCBS needs. It's because of stigma and discrimination resulting from the objectification of people with disabilities and its poor health outcomes. I I have spent so many times going to the emergency department for something and then being told, well, it's not like you're going to use it anyway. We're not gonna address the issue, or maybe we can give you some painkillers and that's it. And the fact that they may not be able to do something for me was not so much the issue, but the way it was presented was, well, you're not using it anyway. The dehumanization in that statement was I can't say more about what it's like. And there are times I would not even go to the emergency department just because I didn't want to hear that phrase. Uh, and and so stigma and discrimination against people with disabilities is also exacerbated by racism, xenophobia, misogyny, and fear of difference. Uh, I can't imagine what it's like for someone who's maybe who's a family of someone who's African American and non-gender conforming, an adolescent, and they who's autistic, and the family's trying to support that child transition to age 22. It just it's daunting. Uh, about 10 years ago, I had a yelling match with a high-level official at Mass Health, and that's the Massachusetts Medicaid office, after a really contentious meeting about the definitional limits of medical necessity and determination codes. Her contention, the healthcare systems are not there to provide everything for everyone who wants everything, who wants something. I contend and still contend today that the state and health plans providing care to the states at the state's behest have a higher obligation in providing service to people with disabilities with medically complex needs as well as cognitive and behavioral needs. The reason? Unlike other people, every aspect of my life, our lives, is mediated by this beneficence model of care that is mediated through medical lens, one that views people with disabilities as patients rather than seeing us as people living in the community. In other words, as I explained to the official, the Americans with Disabilities Act means nothing to me if I don't have the services I need to live in the community and realize my human and civil rights. And that goes for all people. Um, sorry, just I go and I tell people about my experiences with personal care and attendant services and what it's like every year to go to Mass Health and have somebody come to my home to evaluate me for my PCA needs. I am petrified that they're going to reduce my PCA hours because I rely on those PCAs to take care of every aspect of my life. That's from doing my bowel program in the morning, which is an intensive program, to preparing my food, feeding me my food, dressing me, bathing, everything that I need, repairing my wheelchair, all different things that aren't even really included in the assessment for what a person needs to under the Mass Health guidelines or the Medicaid guidelines. I need these PCAs not to enable me to get up in the morning. I need these PCAs to enable me to engage in life and in the community. And so I think we need to really reshape our mindsets and how we think about LTSS. LTSS is not an end in itself. LTSS is not about supporting someone just to live in their home or just to make sure someone's safe and okay. It's really about LTSS is really the 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 uh, the means to living a full life and a full life in the setting that people choose. Um, and sadly, this does not happen for kids transitioning to 22. I'm a really stupid person. I only learn by making mistakes. And I remember prior to staining my spinal cord and becoming disabled, um, I was on campus at Boston University and going by the chapel, and there was someone there who was advocating for the chapel to become wheelchair accessible. And I said for my friend who was walking by, why does that church need to be wheelchair accessible? We can just carry him up those stairs. I had no concept of what it meant to live as a person with dignity when having a disability, and what it would be like to be carried up those stairs. It was only after becoming disabled and having to be carried upstairs and having to be carried up everywhere that I realized that I was losing out on my right as a person to live in the community without the indignity of having to be carried everywhere and be beholden to other people. Um, and so I always learned by making mistakes. And and a number of years ago, again with children, I thought that children would be better at home with their families, again before becoming disabled. I didn't realize what it was like for kids when they transition to 22 and what happens afterwards and until I had the privilege of speaking at the Cotting School in Massachusetts for kids with disabilities. And a good friend of mine, Dave Manzo, asked me to speak at the graduation, and he described the graduation for these kids turning 22 and their families as the best night of their lives, but also the beginning what could be really the end of their lives. And he said that because for a majority of these kids and their families, it was the last night that they'd be engaging in the community, and that for the rest of their lives they'd be isolated, depressed, and alone. And that for me, that for me stuck with me, and has really helped shape the way I advocate for policy. And in addition to the Cotting School, I live around the corner from another school. It's called the Carter School, and this school is primarily it's all kids with really medically complex needs, and African American, Latino kids. The entire school, very low income families, very complex needs, and because these kids don't have access to just basic diapers that work, they spend much of the time sitting in their own feces or sitting in their own their own urine and being having to be changed 3 or 4 times a day rather than being in the classroom getting the services they require to learn how to communicate using communication aids. Um, and for me, this is not a tragedy. This is really a violation of their human and civil rights. These kids should have the equipment they need. There are kids there that this one child, he got a new wheelchair, and the new wheelchair was broken on delivery, and it took another 4 months before they could actually get him to get the wheelchair fixed. Now this young person was sitting in a wheelchair that did not fit him. He was in pain all the time, and that pain was making it impossible for him to actually engage in the classroom. And so to have to go into a new wheelchair that fit him, but he could no longer use, and then have to go back to that old wheelchair was just not only indignity, it seems to me like really a violation of his human rights. The fact that they knew that they were putting him in a chair that caused pain is just wrong. Um, the system is not designed to meet the needs of children's developmental needs, their developmental milestones. Uh, they're just really about a very simplistic understanding of medical necessity. What does this child need now? What does adolescent need now? Rather than looking at the long-term trajectory. What does this child need in order to meet their milestones? What does this young person need in order to thrive in the community once they turn 22? What supports does this family need in order to support this child once they turn 22? What choices do people have? Um, and I think it is really a matter of choice. We talk about providing people a choice, but if they don't have options, then they don't have choice. And so an example would be is saying this is to saying to a family, there are plenty of options for your children, for your child in terms of getting service types of LTSS they can access. But unless the services are actually there for them to receive those services, then then there's no real actual choice. For me, and Rich alluded to this earlier, I I I I feel really strongly with this. We cannot have health equity if it excludes these children. We cannot have health equity or health justice if it excludes the most vulnerable folks in the population. As we saw from COVID, so many of the folks who died in COVID in nursing homes or institutions were folks under 65 with really significant disabilities. And I think as we look at LTSS and think about HCBS, we have to think about it through that lens. What happened to people during COVID? COVID really, I think, should set the benchmark for how we shape and think about how long-term service and support and HCBS should be provided. Um, and in terms of my advocacy work, uh, I'm very grateful and lucky to live in Massachusetts. We've got a forward-thinking state. Get to work with folks like Rich Antonelli. I spent time in Minnesota, so I also am grateful for Minnesota and folks like Jeff who understand that that when we think about LTSS and measuring the quality of LTSS, that we're thinking about the quality in terms of does does the LTSS expand this person's sense of agency. Does this person have access to home health workers, to personal care attendants who can actually get living wages? Because we have to understand that so many folks with disabilities live at poverty level, and the people who are caring for them live at poverty level. Because by definition, in order not to work in the United States, you have to be defined as having a disability that says that you are not able to work. And so there's this reinforcing idea that disability is about what one cannot do as opposed to what one can do. And LTSS should be about the same thing. It should be defined by how does this facilitate the person's ability to live in the community as opposed to how many hours does a person, how long does it take for someone to do a bowel routine? How long does it take for someone to actually to have a person comb their hair? Does this wheelchair does this wheelchair allow the person to just sit up during the day, or how does this wheelchair allow a person to be present in the community? Uh, about a month ago, I received an email from a wheelchair vendor actually about a woman who was trying to get a piece of equipment, a wheelchair had seat elevation in it, and she'd had that seat elevation in her wheelchair, current wheelchair, but the new one was being denied by her health plan. And the reason they said that it was being denied by the health plan was because it did not meet medical necessity guidelines, and that her desire to live in the community independently was not enough for her to get that wheelchair that she needed. And so I went back and I looked at her diagnosis and I wrote a very clear medical necessity requirement, but I also added to that how by not providing this woman access to this the seat elevation, how they were denying her ability to go and thrive in the community. And so we really need to we really need to see that a wheelchair is not just a medical machine. It's about providing someone access to the community. If someone took away the people's cars in this meeting, uh, they would be outraged. If someone defined for us what kind of car we could have, how far we were able to drive, the comfort of that car, uh, we would be outraged. But but this is what happens with people with disabilities. Uh, in terms of uh, in terms of the general understanding of quality of LTSS, the science is new and the science really isn't there yet. And I think that's where I get excited. If you'd asked me 12 years ago if I was interested in data or data analytics, I would have told you no way. But that's what I spend my life doing right now, and that's actually how I got to know Rich. Um, that I got to know Rich by actually uh, engaging in understanding quality measures and how they're important and what do we measure and measures have to be meaningful to actually have an impact on a person's life. And that gets to care teams. I've had really good care teams and I've had really poor care teams. A care team needs to work with the individual. This is really important for children and adolescents turning 22. Children and adolescents need to have care teams that include their families, that understand what the child or adolescent's goals are and what the child or adolescent needs prior to turning 22 and beyond 22. I see in this in the way in what I've learned from being with the Carter School and with folks at the Conning School is this dissonance, this disconnect, this fractured system where kids are able to get access to certain pieces of equipment or things in the school, and they don't have access to those same things at home. So a child might have access to a communication aid at school, but they don't have access to the same communication aid at home because it's considered a duplicative service. Or children don't have access to a piece of a dual of a piece of equipment because it's considered dual use. And by dual use, it means that the device can be used for multiple purposes beyond just being the communication aid the child needs. So that could be anything from an iPad or some other tablet that would enable the child to communicate to another device. Um, Give me 1 second, I apologize. Give me 1 second, apologize. And so we need to do away with policies that would prevent someone from getting the service that they need. I remember from CMS, Tim Engelhardt, from the Office of Integration at CMS, he said he wished he could blow up the the code book and allow people to get access to the service they really need. And this might, I don't know, and this, I guess I would implore, uh, I would implore all medical folks out there to not look at people's diagnoses, but look at what their dreams are. There was a study done in a nursing home that showed that medical providers that were going to support or deny someone's access to the community to leave the nursing home, that if they were provided the medical report prior to meeting the person and talking to the person about their hopes and dreams, they were more likely to deny the person the opportunity to go home than if they spoke to the person first about their desires and their goals. And so it just shows that the medical definition of who a person is really limits their opportunity to live in the community. I'm a C4 quadriplegic with really other complex medical needs that have to do more with my being Irish and just inbred, I guess. Uh, then and so tell me when to stop, Rich. But for me, and the idea that I would be living in the community, I a lot of folks could not imagine it. I was told that I would never be a one-person transfer when I first became disabled. That would always need two people, and I did a one-person transfer for over 30 years without needing a lift or anything like that. It was only until I had surgery that they decided afterwards I needed to have a lift to transfer me more safely. But it's about opportunity. It's about supporting families too. I remember a young man. He was 18 years old, and I was working with him in this second phase rehab, and his mom was still changing his diapers. He had spina bifida, and I was talking to him, do you want to want to go on dates? Do you want to do things? This is something you can do for yourself. You don't want your mom changing your diaper for you. And then looking at alternatives like providing this young person personal care attendant services so that he could actually get the diaper changed by someone else if he couldn't do it himself. And spent so long with him and also talked to his family who wanted him to become more independent about what the opportunities would be for him because we really change we too often treat people as patients who can't do anything rather than people with potential. And that includes employment and community engagement, and that LTSS should be about supporting the ability of anyone who wants to engage in the community. And I'm not talking about closed workshops. I'm not talking about uh, day hab centers. I really mean about engaging in the community, being able to volunteer at a local library or being part of a faith community. Um, everyone like we are mind, body, and spirit. We are not just about the body. And LTSS for some reason is just about addressing the body. And we need to again blow up that code book like Tim said and start thinking creatively about what LTSS should be. And I know there's probably a lot of folks incredulous about this idea and saying no, we have to look at the cost, we have to look at the constraints, and we need some guidelines to understand that like what people are actually getting. I think that's something that really bothers me is we too often look at why are they getting the service? Why are they getting that? Like for instance, why should Dennis be get transportation to go to a movie? But if I lived in a nursing home, people would say, "Oh, that's so nice they're providing Dennis transportation to go to the movie, so we can get out of the nursing home." But the fact that I live in the community makes it a difference that I should not have the ability to go to the movies, that there's services I would get in an institution that I should not be able to get in the community. And so there's this whole cognitive dissonance we have. I think it really comes from this idea that people with disabilities are poor health outcomes, that we're to be pitied rather than respected. and that as we're looking at reshaping LTSS, as we're looking at reshaping how care transitions actually take place for adolescents with disabilities to turning 22, we have to look at it very much as how are we supporting the dignity of this person to live in the community. And the health plan I belong to, uh, started by Dr. Robert Master. His whole focus was ensuring that people with complex medical needs, whether they be over or under 65, had access to the LTSS services they need because he knew that savings would come at some point, that investing in the long-term service and support would lead to reduced hospitalizations, would lead to reduced service needs at different points in a person's life. Uh, was it going to be big cost savings? No, but bending the cost curve did happen, and so when we think about LTSS, we can also look at, if not saving money, how do you bend the cost curve in a way that's that's a result of, as a secondary effect of supporting people's ability to live in the community. Because, and I remember when One Care, the state, the Massachusetts state program for folks with disabilities, dual eligibles, began. I've stated from the beginning and stated always, if you're looking to save money on folks with complex care needs, it's not going to happen. Bending the cost curve will, but as I age, my needs get higher. Not only my medical needs, but my LTSS needs. And so how do we finally break that mindset that only considers cost and does not look at the rights and dignity of people who live in the community. And I know I've said that over and over again, but uh, I think the ADA, as much as I think is a fantastic law, fell short, and this is an opportunity we have. It fell short, and so did Olmsted, in really valuing and pushing society to stop looking at people with disabilities as cost centers, as drivers of cost, and looking differently and saying, how do we make sure that the most vulnerable people in our population and our community are with us at the table? And so as you're thinking about what you're going to be doing and planning, how do you bring folks with disabilities into the conversation? I've seen organizations bring folks in with disabilities into the conversation, but it's tokenism. You have one person or two people, and they really have trouble following what's going on. They don't want to. They don't want to rock the boat. They can't follow the conversations. They get no support, and that's really not engagement of folks with disabilities from the community in the process. Engaging people with disabilities in the community in the process really involves. I think Massachusetts has done a good job with this, providing people transportation to meetings, providing people with disabilities um, stipends to participate in meetings, valuing the work, valuing the voice they bring to the conversation, ensuring that their voices actually lead to change in the process. I can tell you, I've been part of this committee for the One Care Implementation Council for the last 10 years, and we have impacted how Mass Health and how the health plans contracts work. We've successfully shifted some changes in the contracts to to make changes in LTSS, and make changes in utilization management processes, not just for LTSS but other services. It's not, and the state is not doing this because of just out of beneficence, but they see that the money that they're investing into the MCOs is not necessarily yielding the outcomes that they're looking for, and that people with disabilities, if they're going to engage in managed care systems, need to trust the managed care system, need to trust their providers, and they must have true relationships with a provider. And so having a care coordinator means nothing if that care coordinator is a telephonic person who's never met the person that they're working with, who has no sense of what that person's life is like. Um, a care coordinator is someone who has been in the home of that child or that adolescent, has visited and knows the family, can actually work with and transition that young adult to to a provider, to a care team that works with adults with disabilities, and so that they're not with their pediatrician until they're 40 or 50 years old. We have to make sure that we talk about care teams, we talk about care coordination. we're actually doing that in a way that's truly person-centered and is looking at the person's whole, all the person's needs. And that means that you have to have that voice there, and it's got to be an authentic voice, and that voice needs to be really valued in the process and not dismissed. I think going back to my friend Jim, he he his parents listened to everything he wanted. Um, there was even a time they asked him, "What do you want?" He said, "I want to lose my virginity," and they made that happen. They found a therapist who actually became famous. She was in that movie, like movie space, the movie's space. I'm losing it right now, but they brought him to this woman. It's called the Sessions. They brought him to this woman because that was so important to his development as a man for him. And so we think about LTSS. No, I'm not saying get sex service for everybody, but to recognize that people's needs are very different, very unique, and that we can't define some person's needs based on the Medicaid codes or whatever, or the Medicare codes, whatever it may be. We really need to look at what the person wants and what their family wants for them. And I think I've just gone on too long, and I'll happy to
And
answer questions.
Dennis,
Yep.
I want to thank you, and I'm going to encourage everybody to put their questions in the chat or to save them. Dennis, there's so many parts of your story that I have my own set of questions, but I don't want to dominate. I want to give Jill a chance to talk, and then Heather a chance to talk, and then we really want to have a little bit of a round robin. But I want to thank you for talking really about this as both a justice issue and then as an issue of, along with justice, an issue of people's dignity and rights in the community, because I think that's where a lot of people on this call, I think, really believe in that. And I think we really have the opportunity to launch these teams to think about that as well. I'm going
Jeff,
to turn over to.
if I just say one more thing, that
Sure.
even though I sustained my final kidney injury when I was 23, something that happened to my family that I see happens to families of with really complex needs, with children with complex needs, is a family becomes fractured. My parents got divorced. It was just too much pressure for one of my parents. The other parent took on all the responsibility. Some siblings were able to help out, other siblings just couldn't deal. And so even though I don't have that long-term sense of what it's like growing up with a disability, I saw how intensely my family had to deal with my becoming disabled without the support of a care team that really discussed what those needs are and discussed like what the impact was of this disability on the entire family. And so when we're talking about care transitions, we're really talking about a family unit and a family change. And so we're talking about care, LTSS, it's got to be done in that fashion.
That's a super important point for this crowd, and I think for all of us. I'm going to move on to Jill. I have to give one quick nod to Courage Center in Minnesota, which is a wonderful program, and I'm glad to hear that was part of your launch. It's a wonderful institution that I think really changes that mindset in an important way. Jill, I think you have a tough act to follow.
I do.
But we really wanted to talk about, and Dennis hit on, so many things, but some of them are really about how the payer and the policy side interacts. So I'm going to turn this over to you and ask you to spend 10 or 15 minutes really working through some of the thoughts about how that works. It's a pleasure to have you here.
Thank you, Jeff. Thank you, Rich, Meg, and Heather for inviting me to speak and for our wonderful conversations. And Dennis, as always, you're a tough act to follow, but I will attempt to share some thoughts with everyone. My background is I'm a developmental and behavioral pediatrician. I started out my practice working with children and helping families and children with disabilities sort of into the abyss from pediatrics to adults. I did move not long into my career into working at Pennsylvania, which was primarily adults, but not only, to see that on the other side of the abyss is in fact a service system. And not perfect, but there is a service system. And I wanted to kind of share some thoughts about sort of thinking about that transition, but also thinking about kind of what it is to be on the payer side, whether it's working for a state or working for an MCO. And kind of some of the things that I think are barriers to receiving or to having a service system that really meets people's needs. So I'm going to start with a tale of two youth. And I don't want anybody to know who these two are. And so I have just sort of mixed from various stories, but we're going to say two young men turning 21 and transitioning from pediatric services into adult services. And they're both planning to live with their families. The one transitioned to a program where he is able to work 3 days a week. He also volunteers 2 days a week, and on the weekends and sometimes in the evenings is able to go out with friends and do some activities. The second young man transitioned to a program where he spends his days and nights in his childhood bedroom in his parents' home playing computer games. His parents are paid to provide his services, and he spends almost all of his time playing video games and computer games in his bedroom. In thinking about what are the important things to me, and thinking about sort of my payer hat, I have to tell you that my payer hat is colored by my pediatrician hat. So as I think about this, I've spent many years trying to not only think about it, but get other people to think about what should the service system look like. And I think of three important things. One is a smooth transition between pediatrics and adult. And whether that is thinking about healthcare, moving from a PCP, a pediatrician to an adult practitioner, whether it's family practice or internal medicine, whether it's moving your specialists and subspecialists from pediatrics to adult, or your long-term services and supports and sort of those things that help support you to be an active part of your community. For kids, that's moving often from school to maybe a waiver service or to adult services. There are also kids who receive what we call LTSS services, nursing, personal care, and those kinds of things as children, and then also continue to receive them as adults. I think in the continuum of transitions in childhood, because there are lots of transitions, 0 to 3, 3 to 5 programs, the school age, the place where there's a gap and the place where there's the most sort of danger of things not lining up is between youth services and adult services. The second thing that in my mind is really important is that youth transition to a program that will meet their needs. And that may seem like a no duh, but I've seen many people who are in programs that don't really meet their needs. And I've seen numbers of programs who put populations into those programs but they don't have the services that meet their needs. Or they're such a small part of the population that their needs sort of get forgotten or ignored. So I think that it's really important that people have programs to move into that will support them being part of their community and really being out in the community, really like going to the movies, not just sitting and playing video games in your bedroom. And then I think the third thing in my mind that is important is this concept of independence, and as Dennis put it, agency. And I think fostering independence to the extent that somebody is capable of being independent is important. And people will be at all different levels, but that's okay, because part of LTSS's role is to support people where they need to be supported. And I think about employment as being one of the most important things, because often youth coming out of pediatric services have never even thought about working. I'll be honest with you, that young man sitting and playing video games in his bedroom in his parents' house is certainly capable of working. Is he capable of doing something physical? No, but he doesn't need to. He's got a brain, and he's got the ability to use a computer. And anymore, that's plenty to work, and work makes people feel good. It makes them part of a group. And I think it's an important thing to prepare kids for. I think the other things we think about preparing kids, I know that I've been involved in a number of different groups, one at Children's in Philadelphia, around transitioning kids and thinking about helping them to become independent or participate as much as they can in their home care for their health conditions. When people say to me, well, that person couldn't possibly do that, I tell them about my experiences when I worked in child development and in the spina bifida clinic, where we had a little camp for kids in the summer who were going to kindergarten. And the purpose of the camp was to go with the nurse to school and to make sure that they could get into the building, they could get into the bathroom, make sure they knew how to do their self-catheterization, and that they could do that independently. And I said, we taught many kids to do their own catheterization. So people can do things. And if I can teach it to a 6-year-old, I can teach it to somebody who has the physical ability and the cognitive ability to do it. Doesn't mean that everybody can do it, but I think people don't often give people credit for what they likely could do themselves. I know we wanted to talk a little bit about payment models, and I think, there are a whole bunch of things out there that are happening. There are MLTSS models, or managed long-term services and supports, and that's where, and there also are fee-for-service models. Many of those are where you get the medical necessity and the prior authorization and those kinds of things. There's some capitation going on. There are value-based purchasing and value-based payments. Those are typically connected to quality and quality measures. There are some sort of older funding mechanisms that that actually we might think about revisiting. There's program funding where a provider gets a pot of money and they help. They use that pot of money to meet the needs of the people that they are working with. And then there is the concept of individual budgets. And I think there have been some states and some programs that have looked at how do you create an individual budget that the person then manages in terms of meeting their needs, which gives them the flexibility of deciding how they'd like their needs to be met. I do think that the Dennis calls it the medical necessity. I think of it more as sort of DME by DME and PCA or PSA or PAS or whatever you call personal care, personal assistant services, the hour by hour service. But I think that having done that, we have created an environment where the plans and the participants are sometimes adversaries, and I think that's problematic in the sense that there's a lot of expertise at plans. There is a lot of expertise at states, and that adversarial relation, while it's necessary, really sort of misses the point of how do we help meet people's needs. I think that there are a number of issues. Medicaid is often looked at as the place for funding. Medicaid started out as health services, as medical services. They sort of pulled in LTSS stuff with waivers and whatnot, and now adding social determinants of health to that. But I don't think it was originally designed to sort of meet these needs or to think about how to meet these needs. I think it's sort of an add-on. It's had to develop as time goes on. I think that I'm going to talk a little bit about participant direction. That's really kind of an adult concept, participant direction, where the participant is the one who directs their services. They, in many cases, hire and fire staff. They teach their staff what to do and how to do it and how they like it done and how they want it done. I think it's a powerful tool. But it is really often only a very small part of programs. It is not always, we don't always offer people the resources that they need to be able to do this well. And I think sometimes people, because they don't have all the resources and all the information, they'll ask for things that they want to meet a need. But that thing may in fact not be safe, or it may not be the right thing. And so I think we do have a way to kind of approach that in terms of helping sort of figure out what the problem is rather than coming up with a solution first. I often see the solution first, and it's sort of like, well, this is the problem that needed to be solved, but this solution doesn't solve that problem. So I think, sometimes we get into the DME or the home modification kind of wars, and sometimes it's because of that kind of issue. I think we have, I think that the question of who is set and who is ready to advocate for themselves. I think that there's a big gap in that, and I think there's a big disparity there. I think that we don't do enough to teach kids and families in terms of how to not just advocate for themselves, but how to think about what is it that they need, and then work with the people that know about that kind of stuff to figure out what would best meet their need. And I think that that partnership with sort of gaining that knowledge, everybody bringing some of the knowledge to the table is I think a way that is very helpful in terms of thinking about things. I wanted to talk a little bit more about funding really quickly. You know, we now do things as very braided funding, right? So there's Medicaid, there are housing funding, there's food funding with SNAP and food stamps and all that kind of thing. There are sometimes other grant funding that people use to get things that aren't covered by the program. I think that we really do need to think about, is that the best model, right? To pull from all these different things, or would it be better to have a single kind of program concept where you can get accessible housing and you can get support for accessible housing? And I think that requires setting some goals. It requires setting priorities. It requires being informed about services and really creating partnerships. And it requires some accountability and responsibility. And then the last thing I wanted to talk about really quick was measures. I know Dennis and I used to sit on the same measure committee with Rich. I think Rich and Dennis, you're still there. I'm not, but this is a really hard place to measure. I like measures like the Healthy Days measures, which tells you how many days in a month people are feeling good. It's not perfect or magic, but it does give you some sense of how much their health problems are interfering. There are some really basic measures. The rebalancing, are people in the community or in a facility? I think, Dennis, you bring out the great point that just because you're in the community doesn't mean you're part of the community. And I think that that's really important to make sure that people in the community can access their community and actually be part of their community. And I think there's some quality of life, measuring independence, and some of those kinds of things that I'm not sure we're there yet in terms of being able to measure them. But I think what I want to leave you with is I think that I'm with you, Dennis. I think maybe we need to blow it up and start over again and to think about how do we make this happen in a way that people with disabilities become people and become valued parts of communities and workplaces and places of worship and everywhere else that everybody else is. And I'm going to stop there. Thank you.
Jill, thank you so much. I'm going to say what I said in the beginning. We could do an entire academy on this. We wanted to give a few minutes for Heather, who we all know really well, to talk about a specific transition model that she and Rich have worked on in Boston. And then I really would like us to have a little bit of time at the end to be able to talk about the how to move this forward. I know that there's so much to do, but I think that if we could just think about some of I'd love to have people, I'm really enjoying the chat, and also the chat's kind of painful because some states have much more difficulty. But I really want to encourage folks to either put in questions they want to address for the little bit of time we have for discussion, or to put in their best thoughts on what they would like to do to see us be able to move this support and transition forward. Heather, I'm going to turn this over to you, and thank you very much for participating.
Thank you. I have 2 tough acts to follow now. So I do. So I'm really excited to talk to you all today about the integrated care hybrid transition model for youth and young adults with complex needs. A little bit of a backstory before I jump into the project. This is actually how Rich and I met. So very special. I think almost 4 years ago now, I was working as a complex care coordinator in the Boston Children's Hospital Adolescent and Young Adult Clinic. I was the first person to be their complex care coordinator. It was a brand new role. And I had a family referred to me who was getting specialty care within that clinic. At the time, it was a 25-year-old woman with her mother, non-English speaking. They were referred to me for transition assistance as the clinic was realizing, she's 25, it's unclear. Does she have a PCP, sort of what's going on? And we only followed her for subspecialty care. So I met with this family, and they identified Rich Antonelli as the primary care physician. However, the chart didn't match that, and it said someone prior who was her pediatrician from years ago. So I sent an email to Rich and said, "Hi, I'm Heather. I'm a complex care coordinator working in the adolescent clinic. I have a family that's in need of transition assistance, and they're recognizing you as a PCP. How can we work together on this?" I think he answered me in maybe 30 seconds and said, "Do you have time for a phone call?" And then sort of the rest is history. So I will talk in a bit more about what this project actually is all about. So the project aim is to safely transition care for adults at Boston Children's Hospital, primarily in the Spina Bifida Center in the Department of Neurology, from Boston Children's over to Brigham and Women's Hospital and Beth Israel Hospital, employing a hybrid integrated care model. The project goals include assessment of care fragmentation, which I'll talk about a little bit more later, measurement of patient and family provider experience, and the application of quality improvement methodology to improve outcomes of care integration for adult patients with significant complex needs. So what does the hybrid part actually mean? So what we define this as, so the hybrid part is that patients with complex needs, portions of their care that are so specific and so specialized to pediatrics can remain at Boston Children's, but other parts of their care that are maybe appropriate to transition to adult centers, for example, ophthalmology care or renal care, something that is not extremely specific that only a children's center can do, we worked on transitioning those portions of the care. So a little bit different where they're not fully doing all of their care at adult center, but they're still being seen at children's for specific parts of their care, but we're all actually working together now. So the hybrid care integration model takes account of known barriers to transition and transfer. So the integration results from coordination between adult and the pediatric providers with full engagement of the patient and family and the caregiver. We sat on multiple, first it was in-person meetings, prior to COVID, but bringing the families right in and the patient right into the table, talking about the care plan, going over the portions of the care that are going to be able to be transitioned, talking about what the families and the patients' concerns were, where the barriers that they already knew of might be, and working those together with the families with us the entire time. There was nothing that was hidden from them. I would pull up the care plan live on Zoom and we would edit it together with the family saying, "Oh, they just started seeing this new ophthalmologist," or "We actually just got our new wheelchair from this new DME company because our insurance changed." And we just did everything all together and it really worked beautifully. So all aspects of the care that can be appropriately and safely provided by adult providers is what we worked on transitioning. There are certain parts of the care, for example, we have a lot of patients with Rett syndrome, and that is very uniquely pediatric. There's no Rett syndrome clinic at an adult care center. So these patients remained receiving care in the Rett syndrome clinic while also being seen at the adult care center. And we allowed to have the pediatric providers even mentor the adult providers. And myself and Rich would work as that sort of linkage person to be able to connect people, whether it was via Zoom or emails or in-person meetings. When we were able to do those, we were able to coach each other to care for these patients. So those requiring ongoing pediatric care can retain those team members, as I've mentioned. If there's something specific, there's lots of specialized treatments that are out there nowadays or research trials. And it's not fair to say just because you're 22 now or 25, whatever the age of transition may be, now you can't participate in any of those, or you have to lose all of this care just because of your age now. So we really wanted to make it a person-centered approach, as Dennis alluded to, very unique, very person-centered is what patients and families with complex care need, especially during transition. It's not a one-size-fits-all. This model really adapts to the patient and family needs and makes sure that everything is accounted for and anticipating different barriers and different challenges. So why isn't this the standard? I hope that we can make it there someday. This can be different. It could look different depending on what state you're in and where you're at, but it's definitely something that can be adapted and built out really anywhere. So we're happy to share this with you today. And if there's other questions that come after I talk a little bit more, I'm happy to answer them. So I'm going to go over the process map that we created for how we would start out when we would get a patient referred to us. So if you look over at the top left, these patients would get referred to myself and Rich. Either they did not have a PCP, or as we would refer to them as medically homeless. They either graduated from their pediatrician or their pediatrician retired and they had already been 25 or 26 and were still following with them, but then no other pediatrician would take them on in that practice. Or they did have a PCP, but they're also becoming of age and they're thinking of transition. The patients had to be receiving subspecialty care at Boston Children's, and they were identified as potentially ready for transfer of care, whether that was most often was based upon age, or if they needed specific certain parts of their care were really going to be met better by an adult provider, that's when we would get involved. So they would have a consultation with us. Again, it was in person often in the beginning, and then we switched to Zoom. And at this meeting, we would create an action grid. So that tool that we've shared with you all is the primary tool that we would use from the beginning to build all of this out. We would go through each part of their care, often in systems, and just break it down. For respiratory care, they see this provider, they get these meds, this is who prescribes this is how often they need to be seen, this is the DME provider where they get their nebulizer equipment, and really just break it down by everything that was making this patient and family be able to go on. We would then share the action grid with the adult care team and the potential pediatrician. What we would do at that meeting is we would all together refine the action grid and figure out what parts of the care could that adult care center take on, and what parts were they just like, listen, we definitely don't have this type of service within our institution, or there's a 2-year wait list for the sleep center here. Can they get the sleep study done with you guys? And then we can do the follow-up one. We would sit there and have those live conversations and just refine the whole plan so that it was, again, very patient and family centered and thought about as much as we could ahead of time to try to anticipate barriers and challenges. We would then go ahead and implement the action grid within children's and also within the adult care model. The patient and family would meet with the adult PCP. They would go over the action grid, go over the plan. They would have access to myself and Rich through email if needed for questions, also ongoing education about how to best support these patients and families during transition. The adult PCP would then become established with the family. And then the adult PCP and the care manager would determine which subspecialties would be appropriate for transfer. So we would focus first on getting the primary care transferred over. A lot of that just, of course, so they could have a medical home, but insurance does dictate a lot of that as well, at least in Massachusetts, where you need to get established with the adult PCP within that network, and then you can start to see their specialists. So that is something we focused on transitioning first. And then each subspecialist would follow after, and we would sort of go through which one was of most priority for the patient and family. Attendance, but a lot of it was GI. The GI team really needed to be seen for them to get their DMEs. They have to be seen at least every 6 months, a lot of them, to get updated notes. So we would get them in with the PCP and then work on whether it was GI next or whichever one was the priority for the family. We would work on transitioning that next. So this is sort of the overview of the process, and it worked really well to see this all play out. And the families and the patients, to their ability, were involved in every step of the way, and they were sharing the updated action grid with them, and we were getting feedback from them constantly. Just some highlighted areas. So this is a tool that Rich and I had created. I talked a little bit in the beginning about how care fragmentation is something, a barrier that we wanted to break down while we were working with these families. So we tried to figure out where were they at when they came to us, how fragmented was their care. And we made a little scorecard and would give points depending on how fragmented they were. So if they were receiving care in multiple different medical centers, if they had accessibility, we would look at how far they lived, what was their health literacy, language barriers, all of those different aspects. How many comorbidities did they have? We would give a point. If it was a single, it was 0. If it was more than 2, 1. And then if there was additional behavioral, developmental, or intellectual disabilities, another 2. We would then, this was an important one, an extent of PCP engagement. So as I mentioned with the story in the beginning, the PCP that was listed on the patient's chart that had been referred to me was just her old pediatrician that hadn't seen her in multiple years due to her aging out of their practice, but then not establishing care with anyone else until Rich Antonelli dropped out of the awesome sky and was so helpful for all of these patients and families and took on the role of the PCP, or maybe the transition PCP, we could probably call you now, Rich, to help these families get over to the adult care center. Some PCPs were still engaged and we would actively work with them as well. And they would help actually bridge a bit too of bridging the DME paperwork, bridging letter of medical necessity until we got the families transferred completely over. Additionally, we looked at social determinants of health and we would give a point for each. Was there poverty, food insecurity, housing insecurity? Because all of these aspects are absolutely going to affect transition and successful transfer. And then lastly, engagement of parent and guardian and caregiver. Majority of the families that we worked with became very engaged with us and really were taking ownership and wanting to be full partners with us. And it was an awesome experience. So going over the action grid, something we've talked to you a lot about. I wanted to show you how we use this from a transition standpoint and what we did when we would make the bi-institutional action grid. So the way that this works is on the left, you'll see the goals, you'll see the actions, who's responsible for them, when do we want them completed, and then what's the contingency or next step if there's issues. So we want to anticipate issues as much as possible and have plans in place. And of course, knowing that other things may come up, but at least we've tried to think about future barriers and contingencies and have plans for those. One area that we just wanted to sort of highlight that shows what we mean by the bi-institutional action grid is this patient had a thyroid condition and had been followed at children's endocrine, but it was a simple, thyroid condition that an adult endocrinologist can absolutely manage. So we figured that was a good one to transition over. She had had blood work done and was due for her next set of blood work. At the time of the action grid, it was about 3 months after that. And so we decided that the repeat blood work and the follow-up visit would be at the BI endocrine department and worked with that endocrine to place the orders and have everything drawn there. So that was sort of a smooth transition. And we discussed with the family that that would be the plan. And that was going to be the patient's first experience to the lab. I had actually gone with them that day to the lab and they had, it was really awesome. They were all prepared. This was one of their, they didn't have tons and tons of patients with developmental disabilities, but they were prepared and had a ball for her to squeeze and had stickers, and they were really excited and very welcoming because they knew that, they had this background, they had the education, and they were really ready to take her on. It was a great experience. So utilizing the PICS for transition, we've talked to you about the Pediatric Integrated Care Survey. There is a transition module, so it's something you can absolutely start to implement. I just wanted to share an example. We had families complete the PICS before engaging with us in the hybrid model and then after engaging us in the hybrid model. And these are just some sample questions that are around transition. So in the past 12 months, have you or your child's care team given you information about transitioning your child to adult care? So prior to the hybrid model, no. In the past 12 months, have any of your child's care team members talked to you about the process for transferring your child to adult care? No. And then in the past 12 months, have any of your child's care team members talked to you about necessary steps to prepare your child to transfer to adult care? So this was prior to engaging with us. A lot of no's, not really a lot of knowledge about transition or what the process would be or what that would look like or how they were going to be engaged in the process. And then after engaging with us, just shows that, we've talked in depth about transition and the process, and gave the families a voice for how they would be participating with us. CCMT is another one that can absolutely be used for a transition. I'm going to talk a little bit about some of the activities that I did throughout this project and continue to do to support transition and transfer. And I utilize CCMT to document these activities and the time spent and the outcomes prevented. So absolutely something that can be implemented and used to highlight all the transition work that your teams are doing. So the activities that I performed, this is just some of them, but some of the highlights. So facilitated access to care on both the pediatric and adult side. I was sort of that person in between that was able to connect the two, help identify specialists on the adult side. I built connections with different nurses on the adult care side that could help me and help the families transition. And I was also available for them if it was their first time filling out a DME script for G-tube supplies or a formula, things that just are not really common to do on the adult side. But when you're opening your arms to these patients and families, it's something that's very typical that we do all the time and is absolutely necessary. Patients and families need their formula when they need the formula or the G-tube supplies and can't go without. So to be able to be there to teach them how to do that was great. I kept the patients and families engaged throughout the entire process and still do. So we had multiple Zoom meetings with the families. Often it would be about every 3 months for an hour or so to get updates on where we were at with transition, and then also post-transfer and see how things were going. And also was able to share with them the updated action grid and get feedback from them. I assured integration into the adult care setting. So not only are they just plopped into the adult care, but they're actually integrated into the clinic knows them, the nurses know them. The pediatrician was able to connect with the new primary care if needed to give a handoff and really integrate them into the practice and not just have them be a patient's, just a name that's listed there, but have them actually feel integrated. I partnered with adult care providers to learn what their needs were to be able to successfully care for these patients, learned maybe some fears that they might have had, some questions, some unknowns. A lot of them were very open and willing to learn the best of how to care for patients like this. And we were able to provide them with education. And a lot of it was really around the paperwork. They were very nervous about doing like DAHAB paperwork or the letters of medical necessity. And once they got templates from us and just support and knew that we were here, it really took that fear away from them. And then they just were doing what they do all the time, which is care for patients. So that was really great to be able to do that and just sort of normalize, yeah, you haven't done this. So it is totally normal to be a little worried about that, but I'm going to show you how to do it. And the parents or the caregivers are also really great advocates and always like save the letters of medical necessity or the program paperwork and are really great with advocating for that as well. So they were a huge voice in teaching the adult care providers as well what was needed. And then we really tried our best to anticipate the challenges and develop contingency plans. We really wanted to limit the burden that comes with transition and transfer. For example, there could be times where we talked about patients and families losing services during transition and transfer. So we tried our best to keep certain services in place. If there was a PT and OT person that was at a local facility that really knew this family in and out, we tried our best to keep that and not having to change insurances that would then make them lose that provider, and worked our best with trying to figure all of those out to be able to minimize the stress that already comes with transition and transfer. So I think that is all of my slides, but I know that was a lot, so I'm really happy to be able to share that with you guys today. And if there's questions or comments, I think we'll have a little bit more time probably at the end as well.
Thank you, Heather. We are almost at time, and I want to give Beth Lynn a chance to say something. I do want to reflect on the fact that we have a couple simultaneous threads going on in the chat, one at a very meaningful level about finding meaning and not losing and making sure that we have discussions about meaning and spirituality and what is really important to families. At the same time, we have some very concrete discussions about the nuts and bolts of how to make this all work. I want to, I don't think we'll have, besides the chat, I don't think we'll have time for discussion, or else you guys will never get a break and your bladders will stay full. But I want to just say some reflections really that I think are really important, and then I'm going to turn it over. I first have to honor the fact that my mentor in the family world is Carolyn Allshouse, who's on this call. And I had the pleasure of working with Carolyn's family for many, many years. And I learned very much about how a child who has special needs is part of a family. And Carolyn welcomed me in to learn that and to become part of that. And I also have to say then that I learned that the medical model is not the right model for looking at this, but it's one that we seem to have to work our way through sometime. And I think that's important. I want to just say one other thing, and that's that, and I think, Dennis, if you could either confirm, or I think you'll confirm this, I think dignity, rights, and resources are not a zero-sum game. And that's something that we are stuck with sometimes in some states, and we need to get past that. Thank you for listening to me on these things, but I really want to turn over to Bethlyn.
Thanks, Jeff. I am going to be very quick because there was so much that we covered here, and I'm sure there's tons of food for thought for all of you. I think it'll be fantastic to take your time to synthesize and reflect within your teams. I am coming from a world where I worked for a long time with adults with disabilities, and then was able to, on the coin, begin to really see where those bridges were and the commonalities for children, and wondering, why are these so siloed? It just never occurred to me, like, what happened here? So I think one of the things I would point out, fundamentally, this is exactly what Jeff was saying, and what we see in the chat is the two strains. There's this is very meaningful and it matters, and then there's this conceptual way of looking at it. It's justice, it's living a life of dignity, but then how do you apply that in very pragmatic ways that we can use to improve the system with radical incrementalism? And what does that look like, right? So that's what we're charged with, and in the context of care coordination, you can consider, and we've gotten some really great food for thought on what that can look like and what it needs to look like. So that's, I guess I would say that recognizing where the clear similarities and like the PCA services, there's that same fear that everyone has to do this annual thing, and are you going to get the same level? And looking at things like the DME, I know many same stories with those issues, and someone was private messaging me about having that same issue with their child that Dennis spoke to. And the way we need to think about whole person, whole family, mental health, and considering that all together in our measures and in how we develop the models of care. So I'm going to leave it at that. I just think that we can all see that there's many aligned areas for consideration. And the last thing I'll say is that I think families, what I'm seeing now is that families, when they're trying to ensure, they're the ones really ensuring that their child gets the care they need. And it's hard to think about how you help also at the same time build that, what I have friends that are living as adults with disability call interdependence rather than just independence for that child and the family, and help to shift that with them and start building that in the younger years. And that's hard for any parent to do with your child. So I'll just leave that, because I think there are many ways to consider that and start to build that muscle. I have many other notes here, but I'm going to let you continue because it's more important you all get to take a break and be together. So thank you. And thank you for all the excellent work here together. And I think there's a lot more that can be done here. And I think COVID helped to create both the benchmarks for considering this in policy, but also amplified and and exacerbated many of the gaps and the faults of the system that we see before us, and helping us to consider it for moving forward. Thank you.
Thank you, Bethlyn. All right, if everyone wants to go ahead and take a break, we'll come back together at 1:55.
All right. Is everybody back that's supposed to be, Heather? Is it okay to jump right in?
Yeah, I think you can go ahead. It looks like our participant list is almost back to where it was before we headed out. There's a couple teams that might not be here, and then I can let you know when you get to them.
Okay, thank you. So here's where Jeff and I will do some tag team facilitation. I want to encourage everybody. In fact, maybe Heather, can you quick flashback to the questions? There we go. So these are the questions that we asked each of the teams to reflect on. We have the order of the teams on the virtual green board that we'll go through. We are also mindful that 2 to 3 minutes is not going to do justice for what we need to do collectively, and pun was intended. But I want to encourage you, please put ideas in the chat. So let's flip to the green board now. All right, so Michigan is first. New Jersey, you're on deck. Michigan, are you muted?
Let's see, Michigan should be here. I think Teresa.
Teresa? Teresa, you always have thoughtful things to say. Hopefully I'm not embarrassing her because she had to step away. Why don't we?
New Jersey's not here, so we can skip them.
Why don't we jump to Minnesota? Michigan, if you're hearing me, maybe just put it in the chat and then I can call on you, but let's jump down to Minnesota.
Okay, so from Minnesota, where we want to go next and how. We've had a transition task force that has been working side by side with our CORING team, and there's a lot of overlap in membership, but that's just focused on transition within our complex care population. Been doing that for over the last 3 years, and it's hard. Tori Barr, I'm not sure if she's on back with us yet, but she's the lead for that and has been very good about keeping us focused on the important pieces. But to summarize, what we want to go next is make sure that everyone involved in transition, and particularly providers, understand that this isn't a transfer of care. It is a transition of care, and that co-management is going to be needed for a while. I mean, there seems to be this misperception that it's just, boop, we're done. From the pediatric side. And for strategic partnerships, again, partnering with family-led organizations in the different communities across Minnesota. I think that is key to understanding what's needed in the transition process. And our next steps, again, Tori, if you're on, please interject, but we're engaged in some activities more at the systems level. So the state of Minnesota has established a rare disease roundtable, and they will be discussing transition on May 13th. And the focus of that discussion, it's pulling in providers, parent-led organizations, payers, Medicaid, hospital systems to get at the systematic issues that make transition tough. And then also within Minnesota, Tori and Carolyn were both part of a group that applied for funding for a Minnesota-specific Project ECHO that'll focus on transition. And that will start in hopefully sometime early summer. They're looking at June, July. And again, the primary audience is adult primary care providers. again, to talk about the issues and how can we do this better.
Rhonda, that's really great, concise, and then in fact, maybe offline, you and Heather can connect around that because we also started with adult primary care, but I could give you a heads up, they're going to need reinforcements, and so be thinking about those subspecialists on the adult side, especially for the rarer conditions. All right, Michigan, I'm waiting for you to chat, so I'm going to jump ahead to California.
Rich, you definitely jumped ahead. You caught me by surprise, but we're ready. Okay, so actually at Chalk, we've done quite a bit for transition to adult care in the last couple of years. Before the pandemic started, we were kind of planting the seed for a program, and throughout the pandemic, we've actually started the program and piloted our transition program that's called A to B. It stands for Adolescent to Adult Bridge. So we have like the concept so that we can help specialties, and we're going to implement primary care as well, and have already kind of started that. But we also have an outpatient clinic that's devoted to helping the most complex kids transition to adult care. So that's mainly telehealth, but we started doing some in-person clinics as well, and have at least one evening, knowing that families need the evening hours to be able to do that. So a lot of the discussion in our group just now was kind of talking about how, you know, we're doing these individual pilots based on divisions and their needs and what's already been going on, but how can we make that more generalizable so that other areas of the hospital system can be doing the same thing. We talked about the importance of just sharing the tools that we're using. So we're using tools from Gut Transition and from UNC. And in our care coordination program, specifically with our care coordination family meetings that we have that are kind of through the Medi-Cal system, we are actually supposed to include transition conversation within those meetings for kids 14 and up. And for the A to B program, we're even going earlier and starting with 12. And really looking at kind of what Dennis was talking about, like how do we promote that sense of agency, and how do we make it more than just like teeing people up with their DME and all of their nursing care, and how do we look at what they really want to do, and how do we make that happen? And one of the comments was that we really need to learn more about the long-term services and supports for, you know, that are more adult-centered, so that, you know, we can inform them or give them resources rather than just focusing on what's available in the pediatric world. So that's the main stuff that we talked about just now. But it is an evolution, I will say. It's really nice being a part of it. I mentioned that I understand the practicality of doing the hybrid model because not everybody can transition perfectly. And it's a little annoying that it can't be seamless all the time, but it's understandable. So just like really, you know, talking families through what conversations they should be having when they see their physicians, whether it's primary care, specialty care, at their, you know, when we're having a family meeting, for example, we're saying, oh, you have this upcoming GI appointment and, you know, your child's already 19, like ask them how long they'll see you. Ask them if they have recommendations for you when you get closer to, for us, it's 21, you know, what are their expectations, so that, you know, people can understand next steps and have some, feel empowered to ask those questions rather than wait till it happens to them.
Annie, thank you. And I know that you and your team focus around sustainability. So one of the other reasons to identify who the patients are that are going to need the hybrid approach is so that it gets baked into the per member per month allowance for care management. That's actually been some of the magic between our work with now potentially adding a third system. So these are not individual PCPs, they are systems of care. So think about that. All right, so next is Texas and Kim Brown from Montana. Thank you for helping us manage the time. So Texas, your report out, please.
Hi, this is Rahel. I have rather unstable internet right now, and maybe I'll have Maureen also help. A couple things that Maureen suggested that would be practical is after we and maybe Maureen, you can present this piece of it. The other piece is the sort of the big dream of having a strong complex care clinic with a strong PCP that uses the specialists as a consultant, which is integrated with, again, a strong adult PCP with the component specialists.
I think Rahel has frozen. Maureen, are you prepared to step in?
Yes, I can. Rahel is our visionary dreamer, and I'm like in the weeds with the practical details. So here's my
I'm a member of the
Go
Rahel
for it.
fan club. Totally. Go ahead.
And my first stems has to do with community organizations, and in our state, our Texas Parent to Parent has a program that is called medical education, where we bring pediatric and some family practice, but mainly pediatric residents into the homes of children with medical complexity or actually any kind of disability, and give them a little day in the life of these children. Like, what's it like at home when we're not in the hospital? How do we do it? And then, you know, a family life, and make it kind of engaging and appealing. And I would like to expand that program into internal medicine residents and adult PM&R residents, neurology residents, and, you know, for adults providers. Right now, we're just doing pediatrics. And it's driven me crazy for a long time that this conversation only happens on the pediatric side. We really need to, you know, it's two sides. It's the bridge to nowhere if you don't have adults involved. And my other thought was that developing a database in the pediatric comprehensive care clinic by checking in. I borrowed it from your hybrid model at Boston, but checking in at 6 and 12 month intervals after the pediatric patient has graduated, and just check, did those referrals work? Is it, you know, or not? Does the front office staff at that internal medicine office treat you respectfully or not, which is often where the problem begins. So those are just a couple of, anyway, that way you develop a database, but you're also check in, and your patients feel a little less like they've just been shoved out the door, never to be seen again by their pediatric family. So that's me down in the weeds.
That's wonderful weeds, by the way. And I can tell you at a national level, we're trying to build some questions into the National Survey of Children's Health, which is not just measuring on the pediatric side of the bridge, but on the other side of the bridge as well, because it's all of the measurement essentially is on the pediatric side. We need to make sure people equitably find their way to a safe medical home. So thank you for that. All right, for the sake of time management, I am going to recognize the teams that have put stuff into the chat, but I'm going to continue to follow the blackboard or green board, as the case may be. Kentucky.
Hi, yes, I'm Michelle Mara from Kentucky, and I can tell you this conversation, I think we could have talked for a lot longer, throwing out ideas and things that we would like to do, and certainly hearing from just the members of our team that have personal experiences. So it was a good catalyst for some good conversations. So I appreciate that. We currently have a pretty robust transition program, and we do document, you know, what we are doing, but I absolutely agree. It'd be great if the adult providers were meeting us on the other side of that conversation. We talked about, because we currently have nurse coordinators and our social workers and our family representatives who work with our families. And we have set times where we're really focusing in on this and talking about the transition into adulthood. But we also talked about how we could do a better job of building those contacts out in the community, and talked about a lot of ideas about how we could possibly do that. One of the first things we'll probably do is survey our Kentucky providers to kind of see what their comfort level is, what do they need to know, and how we can, maybe provide them with the information. And again, we had lots of discussion, just different ideas of how we could do that. We talked a little bit too about strategically partnering with possibly some of our dual internal medicine and pediatric or family residency programs at the local universities, and how we could, partner with them or even our local school systems to help with just the whole idea of transitions being part of that conversation all the time for multiple entities. We also talked about really how we could do more of that outreach with our adult providers, how we can kind of meet them and help them understand more about what our program does so that they know why we're even here and what we are doing for the children in Kentucky, and how they can hopefully partner with us to help with those transitions. So I'll try to put that, it was hard to type because I really wanted to hear what everybody else was talking about as well, but I'll try to get this typed and put into the chat.
Michelle, that's wonderful. And, Kentucky, for the rest of the Academy, joined us in this additional year, and you guys have been just standouts. And I love the affiliation from the Title V program there. So we look with great excitement as to what's to come for Kentucky. Thank you for that. I think that the Philadelphia team had to step away. Montana has put a summary in the chat, so I'm going to jump to Florida. Are you prepared to share your report out?
Sure. Can you all hear me okay?
Yes.
So I'm from the Florida team, and in terms of our transition plan, we are looking at it fairly practically. So in terms of where we'd like to go next, I think we kind of look at it as taking place on multiple planes. So there's a lot that needs to happen structurally, obviously at the national level for support around policymaking and payer support. The state level in Florida in particular has been doing a lot of work, and there's still a long way to go, as demonstrated by results on national surveys of children's health. But looking at it locally, which is what we're able to more easily affect, we are looking towards structural change at our organization. How do we do this? Well, we think that a lot of, just in the practical management day-to-day of patients, a lot of our barriers have to do with access to care, and specifically access to adult care for patients with Medicaid insurance plans. And, it is a lot of structural problems that we're going to partner with leadership at the systems level. We've started these conversations, of course, as well as at the individual practice level of the different specialists across our organization that we're trying to work together with. And most importantly, family voices are what often opens the door and continues the conversation in a way that's much more powerful than any of us individually. And so those voices remain at the center of this work. Our next steps, we are, applying for some grant funding for some legal supports along the, guardianship and support decision-making pathways. There's some ongoing work in curricular development that is being utilized in all of the pediatric specialty, not all of them, but many of the pediatric specialty clinics to help with, written documents and booklets that patients and families can take with them along their transition journey. We're trying to build an EMR supports to both track the transition process, as well as make it, reinforce the systematic nature of it so that it's taking place similarly at an organizational level. And then finally, we have to figure out how to measure it so that we can track our success and continue moving the dial forward. How do we integrate LTSS, well, that's challenging, as we all know. And a lot of it here happens in the form of waivers and how the family's budgets are made and what kind of services get poured into those budgets. And so, you know, some of it takes place at the level of the local, which is, you know, the practice and the family. But I think a lot of it, in our case, is we will look to the leaders of our state and of our nation to also help move the dial forward in this important aspect of care. So that's a quick update on our end.
Kristen, thank you. And I just want to acknowledge, as I did with Kentucky, the voice of Title V in Florida in the person of Jeff Brosco is remarkable. And I think that you are focused on some key opportunities to move forward. So thank you for that. So I think I've gotten input from all of the teams in chat, but I want to make sure that I haven't missed anybody. I know that SBA Hershey has weighed in. I don't know whether SBA Cincinnati is present, or I did notice, Judy Thibodeau, that you're here. And if there's something that you would like to offer on behalf of SBA not related to Hershey, I'd give you the floor. Okay, so Judy's not here. So is SBA Cincinnati with us? Okay. Thanks, Denise. You're amazing. You're taking care of your own team and your colleagues as well. Thanks so much. All right. So I think, why don't we go ahead? I guess, Heather, I know you're about to hand it off to Jeff, but I want to, if you could just describe what's going to happen with our internal team in terms of the valuable insights and discussion that went into chat, so that the teams will know how they will be eventually seeing some of that wisdom, and then you can hand it off to Jeff.
Absolutely. So we will post everything to Open Pediatrics. Majority of the content should be up by later today, pending large files and things that might need to be broken up and take some time to upload. Additionally, we will pull out resources from the chat, and we can also upload that as well to Open Pediatrics, and you will find it under the tile that will be labeled for today's session. Now I'm going to jump over to Jeff so he can explain what will be coming soon regarding our Academy evaluation.
Alrighty, everybody. There's really two different things that are coming to some of you, and I'm going to start over on the right here. And that's that there's a process evaluation that is really about what people have learned and the running of the Academy, and sort of whether, you know, we get our feedback from the sessions, which we appreciate, and we get our feedback from looking at how many people are still here, which we appreciate, but we want everyone to sign on and tell us what we could do better and what you learned. That's the process evaluation. There's an impact assessment that's really not part of that formal evaluation, but this is really for us to say, did we advance, did we help you advance your three-legged stool approach to designing your program? And if so, what did you, what was successful? This is going to team leads, and we have a separate one we're asking the family partners, because we want to make sure that emphasis is there. So we'll see what's there. Part of this impact assessment is also something that I know that the folks at the CMC Coin wanted to know whether or not there were any work products that are shareable. And work products could be like a clinic flow, or it could be like, you know, how you agended your team meetings. So we'll ask you to do that as well. So look for these things. Do not delay. Open them as soon as you get them and fill them out right away. That's my push. But anyhow, and then one last slide from me before I turn this back over. Okay, I've been to enough summer camps to know that you have, at the last night before you go, you have a campfire. And our next session is really I would say the campfire before we all put our arms around each other, sing Kumbaya and say, we'll see you next season or whatever. But I do want to say that it's really important because what we're trying to do at the next session, which will be in June, is we really want an opportunity to tell, we want an opportunity to hear from Title V about the blueprint, which some of us have been really involved in. And I want to just say that the blueprint has been informed by this work, the work of this group. And we want the blueprint. We want also to have this group be able to talk to some of the folks at MCHB about what worked and what you'd like in the future from MCHB funding to support the work that you all are doing in the real world. So, so we'll be having our virtual, I guess I would say our virtual campfire next time, and I'm looking forward to seeing all you in June, and we'll get that date out very soon. Heather, I'm turning it back over to you, I believe.
Thank you, Jeff. So thank you, everybody, as always. We are going to send out the evaluation link in the chat right now for your feedback on today's session. As a reminder, if you are requesting continuing ed credits, please fill out the evaluation and also the attendance link. I will send those links out later this evening as well in an email. As we've mentioned multiple times today, we are changing the May 31st date to a date in June. That date is still to be determined. A calendar invite will be sent to you, I would say, in a couple of weeks from now. We will end up canceling the calendar invite for May 31 and sending you a brand new invite. So you will have to re-register. That will just prevent any issues that we had run into before when we had transitioned a meeting. I think when it requires registration, it requires it to be canceled. So we will have you re-register. And then we will come back for our final session, and we will send you information about what to expect at that final session before as well to have you prepare. As always, it's great to see you guys. Reach out with any questions or concerns, and we will see you in June. Thank you so much. Have a great rest of the day.